Placenta is an organ that is discoid in shape and it has so many properties. So placenta is basically an organ that is providing all the nutrition, all the oxygen and everything that is required by the fetus in order to grow. So, if we want to see our placenta and what is present inside of it and what are the blood supply of placenta, that is the most important part. All the nutrients that the fetus is getting, all the oxygen that it is getting, all the toxins, all the byproducts of any type of medicine that the mother is taking, everything that the mother is taking can go to the fetus via the blood supply to the placenta. So we will be discussing about so many aspects about placenta and umbilical cord in this lecture, and how these infections that are basically mother borne, they are present inside the mother and she was affected somehow, how they get transmitted from mother to the fetus via placenta and via umbilical cord. So we first of all, in this lecture, we will be discussing about the anatomy of placenta. Now, if we talk about the structure of placenta, it is a discoid shaped flat organ and it has two sides. The one side that is known as chorionic or amnion is facing the fetus and forms the basically consists of the amniotic fluid, and inside the amniotic fluid fetus is present. The other side is the decidual side, or because of the desudation that occurred inside of it during the process, it is known as the decidual side of it. The decidual side is present and facing the mother. So it has two sides, the amnion or the chorionic side and the decidual side, and we have discussed about it, how they are facing each other. Okay, so now starting to see the anatomy. Now over here, this portion, this one is basically showing us the placenta. This over here red portion is the umbilical cord and this obviously is the fetus. Okay, now the first thing over here, the outer part, is the decidua basalis. Decidua is the part that is facing the mother's side. So this area is present over the mother's side and this lining is basically facing the fetus. Then we have chorionic plate. Now these two, the chorionic plate and the amnion, these are the two innermost layers. This one is the chorion and the innermost is the amnion, and inside the amnion is the amniotic fluid and the fetus. So this one is the part facing the mother, and these two, the chorionic plate and the amnion, is the part facing the fetus. Then we have cotyledon. Cotyledon is basically the center of the whole structure. If you can see these parts, these are the central portions, or you can say the main building block of the placenta. Then we have main stem villus over here. These areas are the villi or the villus, and these villus are responsible for the absorption of all the nutrients, all the oxygen and everything that is required by the placenta, by the fetus. There are also villi present in our body somewhere else. They are present in the small intestine of the person, and they have the same function over there as well. They from the material that is moving from the stomach into the small intestine, their job is to absorb all the important nutrients effectively from that material that is passing through the small intestine. These villi have the same function. These structures we are seeing over here that are tree-like absorb all the important nutrients. Then we have placental septum over here, this one. Endometrial vein, this blue part is basically showing us endometrial vein, and this red part is showing us endometrial artery. Now blood enters into the placenta from endometrial artery and it leaves the placenta via the endometrial vein. Now if you can see this portion over here more clearly, Now this one over here is the spiral endometrial artery. This is intervillous space between these villi. Now, the blood that the endometrial artery is carrying towards the placenta is poured inside these intervillous spaces, and from this intervillous spaces, everything is absorbed that is required. So, these system, the blood supply system of the fetus and the mother are totally different from each other. It has no the only connection between the mother's blood with the fetus is that it is poured in these intervillous spaces, and from here it is being absorbed. And if you can see this connection, these veins and arteries, they are forming basically umbilical cord. Umbilical cord consists of one vein and two arteries, and these arteries are usually spiraling around this big vein. So the red portion over here is showing us the vein, and the blue are the arteries. This is the endometrial vein, this blue one. Okay, amnion, this is the innermost portion over here, like this one. Then we have umbilical arteries, these blue ones. Umbilical vein, this red one. Okay, so we have discussed about the arteries. So in this diagram, yes, we will be saying and discussing only about the blood vessels that are supplying the blood to the placenta, and from placenta how the blood reaches, or the nutrients will be more specific word, reaches the fetus. Okay, this is the endometrial artery, endometrial spiral artery. This is the further division of the endometrial artery. First of all, the endometrial artery approaches the placenta and then divides into endometrial spiral artery. Then we have this blue one, that is the endometrial vein, intervillous spaces, and all the absorption of nutrients, absorption of oxygen, absorption of everything that is required by the fetus in order to grow is carried out over here in these intervillous spaces. Then we have anchoring villus over here. Then we have myometrium, basically the muscular portion of the endometrium, that is known as the myometrium, the muscle part. Then we have cytotrophoblastic shells that are covering the villi. The decidua part that is facing the maternal area. Then we have umbilical vein, the large one, and these two are, this one is the umbilical vein. And then we have chorionic vessels. These chorionic vessels, the division of the endometrial vessels, the division of these vessels basically make up a chorionic network inside the placenta. And if we talk about the term of the pregnancy, almost this surface area is covered by these chorionic vessels, 60% in the cross section, and other areas covered in the 40% portion. And this is the amnion and smooth chorion. Okay, so now we will be discussing about the abnormalities of the umbilical cord, but before that, there are different sizes of placenta. Depending upon the growth of the fetus and the time of the pregnancy. If we talk about the initial time, for example, 30 weeks. If at 30 weeks, the size of placenta is usually more than and between 350 grams. If we move forward and we say that at 35 weeks, the placenta is around 434 grams, and at the term, at 37 weeks to 40 weeks, placenta is about 500 grams. Now, placenta can be large in size and it can be small in size as well. The small placenta, the main reason for a small placenta is the hypertension in the mother. Because of that, the placenta remains small, and babies that are reproduced are usually have low birth weight. And the placenta can be large. There can be edema at the level of villous. There can be any hypertrophy. There can be metastasis. There can be umbilical hydrophs, and so much more. So any disease that is causing the placenta to become large produces a placenta that is up to 1000 grams of size. Now, this was about the shape of size of placenta. If we talk about the shape of placenta, it has different shapes. The biloid shape, that is it has two parts and they are equal in size. Then we have circumvallate size. Then we have two or three more different shapes of placenta. Um, the next thing that we will be discussing are the abnormalities of the umbilical cord. Umbilical cord can have different abnormalities. It can be related to the shape of umbilical cord. The umbilical cord can be tied around the neck of the child, or it can be torsioned around itself, and so much more. So in this slide, we will be discussing about that. So umbilical cord abnormalities, the first one is the length of the umbilical cord. It can be very small and it can be very large. The very large umbilical cord can tie around the leg of the child, the wrist of the child, neck of the child, and if it is tied around any extremity of the child, and if it is impeding the blood supply towards that area, it can lead to growth restriction in that body part. Then we have cord coiling. Single umbilical artery. It has two arteries that are coiled around a single vein, but if it has one, that is the abnormality, of course. Four vessel cord, it has to be three vessel cord, but it can be four if there is any abnormality. Abnormalities of the cord insertion, where it is inserted. Cord abnormalities capable of impeding blood flow. We have talked about three conditions. It can be tied around the neck of the child, that is the most dangerous one. It can impede the blood supply to the brain of the child. Then it can be around any extremity as well. Then we have torsion and strictures inside the umbilical cord, and because of those torsion and strictures, the blood supply carrying all the nutrients towards the fetus can be blocked, and that is a serious situation. Then we have hematoma. Any injury inside the umbilical cord can lead to the collection of blood over there, forming a hematoma. And the last one is the presence of any type of cyst in the umbilical cord. So this was about the abnormalities that are found at the level of the umbilical cord. Okay, now coming towards the immune tolerance in pregnancy. Whenever there is conception, the child or the umbilical cord or the placenta, they are considered to be the allografts. Then why doesn't the mother's body is rejecting that allograft? There are no immunosuppressions that are given to the mother or no other type of drugs, but there is no reaction between the mother's body and the fetus. So that is because of the reduced immunity inside the mother. And that is a physiological process. We will be discussing about the whole process in this slide as well. So starting the whole process, first of all, the process starts with the ovaries. Ovaries usually produces hormones that are the progesterone immunomodulators. These immunomodulators interacts with the immune cells inside the bodies that are different type of cytokines and etc. These induces the PIBF, and it has two results. The first one is the production of NK cells cytotoxicity and the decrease in INF, that is the interleukin factors, and this causes immune suppression. Other than that, the other process is the production of Th2 cytokines that are the interleukin 3, interleukin 4 and interleukin 10. They are increased. Then what happens? that drugs or CD4 and CD25 are increased. All of these are the inflammatory cytokines that are found inside the body whenever there is some inflammatory or immune reaction taking place. All of this one, increase in CD25 and CD4 leads to immune suppression. These two processes we have discussed about. Okay. Then interaction with the immune cells on the one hand was causing this process, and on the other hand it is causing GAL1 to increase. Now this increase in GAL1 causes inhibition of pro-inflammatory responses in the disease and favors the induction of tolerogenic DCS. And this also reduces the immunity and is immunosuppressive. So basically the first interaction of this progesterone with the immune cell produced these three reactions, and all of them are producing one result, that is the immune suppression and again the fetal tolerance. Now at this level, if the inhibition of tissue necrotic factor alpha and the nitric oxide or the NO production takes place, this also results in the decrease in the immunity or the immune suppression. Now all of these processes together are causing only one thing, that is the immune suppression, and as a result is producing fetal tolerance. That means that the mother's body is now unable to reject the allograft that was the fetus, and that is the main reason there was no rejection. Okay, now we will be discussing about the placental infections. There are so many of them. Some are minor infections, some are majors. So we will be discussing about them accordingly. The first one that we will be discussing is the chorioamnionitis. So this disease is basically telling us that chorion or the amnion part of the placenta, that was were the portions that were facing the fetus, are going to be affected. If we talk about the etiology of the disease or the causes, there are different organisms including the virus and the bacteria. First of all, they affect the mother, and from mother they get their area or their side towards the placenta, and from placenta they affect the fetus. So basically the origin of the disease or cause of the disease occurring in the placenta is the infection present in the mother. So the first organism is the B. streptococcus, Escherichia coli, Enterococcus, other staphylococcal species, and Staphylococcus. All of them are the bacteria. Then we have gram-negative bacilli, bacteriocytes, Mycoplasma hominis, and then finally Ureaplasma. All of these organisms, any one of them, if is affecting the mother, will be affecting placenta and then fetus as a result of that. Now in the next slide we will be discussing about the risk factors, then all the pathogenesis, and then finally the sign and symptoms of the disease that are produced first in the infant or in the fetus and then in the mother. Okay, so starting the slide with the risk factors. The first risk factor for the disease is the prolonged labor. Then we have PPROM and PROM, that is the premature, prepartum, peripartum rupture of the membrane, and this is the premature rupture of the membrane, and that membrane is of the placenta that is attaching it towards it with the mother. Then we have bacterial vaginosis, multiple digital exam with the membrane rupture, Group B, strep positive bacteria, alcohol and tobacco use during pregnancy, and nulliparity, that is it is the first pregnancy of the mother, and then finally we have meconium or the meconium. All of these are the risk factors for the disease that we are talking, that is the chorioamnionitis. Now, what usually occurs that ascending infection from the lower genital tract produces a disease that is the inflammatory infection of the chorion and amnion. Now, activation of fetal inflammatory cascade inside the fetus, the sign symptoms that are going to be produced. The first one is the fetal tachycardia. Then we have perineal death, neonatal sepsis, pneumonia, intraventricular hemorrhage, and then finally we have long-term morbidity including cerebral palsy. If the child has been born, he or she will be suffering from severe diseases and will suffer from these diseases in a very long period of time in the coming life. And if not, these type of diseases such as neonatal sepsis, perineal death, and fetal tachycardia, all of these can be the result of the and can result into the death of the infant or the fetus. Now, these are the symptoms or the signs that we will see at the level of the fetus. But what will happen at the level of the mother? Activation of maternal inflammatory cascade. Now, these are the sign symptoms that we are discussing that will be happening inside the mother. The first one is the maternal sepsis, endometritis, postpartum hemorrhage, pelvic abscess. Then we have maternal fever that is more than 38 degrees centigrades, uterine fundal tenderness, maternal leukocytosis, purulent amniotic fluid, maternal tachycardia, and then finally amniotic fluid culture positive for microbes. All of these are the signs and symptoms that will be seen in the maternal body because of the inflammatory process that is taking place over there. Now, this process, that is the activation of maternal inflammatory cascade, will result in different forms. The first one is the release of prostaglandins and then membrane rupture. Now, if there is release of prostaglandins, there are going to be contraction and cervical ripening. And if the membrane is ruptured, there is going to be preterm perinatal rupture of the membrane, or there can be preterm rupture of the membrane. And both of them will lead to preterm birth. Any birth that is even one day before of the completion of the 37th week is known as the preterm birth. So these two can lead to the birth that is the preterm. Okay. Now coming towards the pathology of the chorioamniotic disease, amnionitis disease, the first thing that we will be seeing is the acute subchorionitis. The process will start from the chorion. It will then further move towards it will involve the amnion part as well, and the disease will convert itself into chorioamnionitis. Then it will involve the other portion of the placenta, that is the decidual part, and will lead to acute deciditis. This deciditis will lead to the necrotizing deciditis, and finally we will be seeing different and numerous microabscesses in the decidual part of the placenta. This is the microscopic view showing us so many, if you can appreciate these blue small dots, they are basically showing us so many microabscesses inside the placenta in the decidual part. And if you can see it more clearly over here, this is a microabscess that is present because of the necrotizing function or the feature of the disease. Abscesses were formed in the placenta. Okay, now the second disease that we will be discussing is the amniotic infection syndrome. So, amniotic fluid is the fluid in which the child is present, and any disease that is infecting the amniotic fluid will lead to amniotic infection syndrome. The source of the disease is going to be mother, and the organism will be transferred from mother's blood into the fetal blood in the intervillous spaces, and will reach the fetal area and the surrounding environment from the umbilical cord, and hence the amniotic infection syndrome will result. Now, amniotic fluid is basically composed of, initially it is composed of the transudate fluid that is taken up from the mother. But when we move forward in the pregnancy and the child has developed its own organs, it is usually formed from the lungs and the kidneys of the fetus. Now, this amniotic fluid moves inside the lungs and outside the lungs of the child when he or she breathes. So, any infection that has infected the amniotic fluid will infect the fetus via his or her lungs. He or she will inhale that amniotic fluid and it will reach his or her lungs, and from there the infection can disseminate and reach the other areas of the body and can also lead to diseases like sepsis. Okay, now we will be discussing about different infections that are taking place in different areas of the placenta. So the first one is the Villitis. Villitis is basically showing us that there is some type of infection that is present inside the mother, and the part of the placenta that it is affecting is the chorion, and the organism basically got its entry point into the fetus or into the amniotic fluid or umbilical cord was via the blood that was poured into the intervillous spaces into the placenta, and from there it was absorbed by the blood supply of the fetus, and it was then transported over there. So if we talk about the pathology of the Villitis, this is a cross section that is showing us the part of the chorion of the placenta, and these areas over here, these dark purplish areas, are showing us the nuclei of the cells that are being affected or infected by these organisms. Okay, now talking about the etiology, there are different organisms, bacteria, viruses, and so much more that can affect and can be the cause of Villitis. So there is a whole list of organisms that we will be talking about in this slide. So the first one are the bacteria. All the bacteria that causes the Villitis are, first one is the listeria, Treponema pallidum, M. tuberculosis, that is the Mycobacterium tuberculosis, Mycoplasma species, and then finally we have Chlamydia species. These are the bacteria if they have affected the mother somehow, and they can enter into the placenta and then into the fetus. Then we have viruses, rubella, cytomegalovirus, herpes simplex. Now these three, if you can see something common in them, they are the part of the torch agents. Torch agents are the viruses that affect or infect the fetus in the most dangerous ways. The one missing from them is the Toxoplasma. Then we have parasites and protozoa. We have Toxoplasma species and Trypanosoma cruzi. The final one are the fungi, and the one that is causing the disease is the Candida species. Now you can see there are so many organisms that can be involved, and the only way we are going to find out that which one there is, we will be performing the histological test on the sample that we will be getting from the amniotic fluid or from the mother's blood or from the other sources. After examining that, we will find out the cause of the disease depending upon the features of these organisms, and according to that, broad spectrum antibiotics are usually used for the treatment of the disease. The next disease we will be talking about is a very important one that is known as the cytomegalovirus. The basically cause of the disease is the cytomegalovirus and is the part of the torch agents. So torch basically it stands for T over here stands for the toxoplasma, R over here stands for rubella, C is for cytomegalovirus, and H is for herpes simplex virus. And all of these are usually transmitted to the fetus via the cervical canal and ascends into the body and gets into these areas. So, 30% of the pregnant women without CMV antibodies. So, here it is telling us that out of 100%, there are 30% of the pregnant females who do not have any prior antibodies against the cytomegalovirus inside their blood. So, what can it do now? 1% of the primary infection during pregnancy. Out of these 30%, 1% is usually affected, and 40% fetal infection. So it has now two outcomes. The first one is that 80% cases are going to be asymptomatic out of these 40%. Now, 90% of them, of those fetuses will develop normally, but the remaining 10 will develop sequel of the disease, that is the cytomegalovirus disease. Now, the other condition is, now these children, these 10% of them will develop hearing difficulties and mental retardation, that is basically the result of the cytomegalovirus infection, and 3% of the primary maternal infections. Now, the remaining 20% were symptomatic, and out of those 20%, 90% 90% will develop sequel of the disease, and 10% will develop normally. 20% symptomatic fetus we are talking about over here. Okay, now as a result of that, these 90% fetuses will develop mental retardation, hearing difficulties, and motor retardation as a result of the cytomegalovirus infection, and 7% of the primary maternal infections. Now, fetal growth restriction, hepatomegaly, ventriculomegaly, microcephaly, purpura, and retinitis. These are all the signs and symptoms that we will find in a neonate who will be born with the cytomegalovirus. Now, 70% pregnant women with CMV antibodies. Was the first condition in which we found 20% symptomatic of infants, and out of those 90% developed sequel. But now in this case, in which the 70% pregnant females were immunized against that or had a prior antibodies against that infection, then 0.2 to 2% fetal infection due to reactivation of the organism inside the body. And out of that, 0.5 to 1% symptomatic infections will be produced. So presence of antibodies against these type of viruses is important when we are talking about the prevention. Okay, now coming towards the pathology. Whenever the child is suffering from cytomegalovirus, we will be finding that the placenta has been enlarged. Placenta can be enlarged up to the size up to 1000 grams. The normal size for the placenta, that is up to 40 weeks of age, is 500 grams, but it develops up to double of its size because of the edema that is present in the villi or villous area. It can be any type of sarcoma that it can convert into, and cytomegalovirus is very famous to convert into some type of sarcoma or carcinoma. Now in this slide over here, we are seeing certain abscesses that are found inside the placenta as a result of cytomegalovirus infection. This over here is an abscess. Okay. Now, moving forward towards the syphilis, this disease will also have the same route of infection. It will follow from the maternal infection. At the second stage of disease, it is more potent or more prevalent in the fetus. So, once the disease has occurred and the organism has made its way from the mother to the fetus, there are certain signs and symptoms that will be presented in the fetus. So, these signs and symptoms will be stillbirth, that is, that the child died inside the amniotic fluid or amnion. Premature birth, that is the birth before the 37th week of completion of 37th week of pregnancy. Then we have hepatosplenomegaly, enlargement of spleen and liver as a result of the portal hypertension or any other difficulty in the blood supply. Then we have snuffles, lymphadenopathy, mucocutaneous lesions, pneumonia, edema, rash, hemolytic anemia, and then finally thrombocytopenia. All of these are very serious signs and symptoms of the syphilis that are seen in the infants. Okay, so now talking about the pathology of the syphilis. Like the previous disease we have discussed about, the size of the placenta also enlarges in this, and usually necrotizing phinitis is usually seen in syphilis. Other than that, the hypertrophy or the hypercellularization inside the villus are usually also seen, and these areas over here basically showing us hypercellularization in the villus. Okay, now talking about the next disease, that is the listeria. Listeria is caused by ingesting the contaminated food. The contaminated food is obviously is going to be ingested by a mother, and if she is affected by listeria, the child can also be affected. And if the listeria reaches the child, the following signs and symptoms can be caused. Before discussing about the signs and symptoms, I want to tell you that almost 5% of the patients affected, neonates, more specifically affected with listeria, gets or develops cerebral meningitis. Now, talking about the clinical sign and symptom, the first one is the miscarriage. Then we have stillbirth, premature delivery, granulomatous rash, pyogenic granuloma, and the last one is the neonatal meningitis. These are all the very serious signs and symptoms that are usually seen in the neonates because of the listeria. Now, if we talk about the pathology of listeria, there is hypercellularization and enormous amount of micro abscesses are usually seen. If you can see these areas over here, they are filled with micro abscesses. This is usually the appearance of the chorion and amnion when the child is suffering from listeria. The next disease is the Toxoplasma, or the causative agent in this disease is the Toxoplasma gondii. So, Toxoplasma enters into the maternal body via two routes. It is present in the cats, it is a known source, and there is another source. The first one is the human ingests the raw meat containing cyst with bradyzoids. They are present in the pig meat or the pork, and if the food is ingested in the uncooked form or not properly cooked form, those cysts that were consisting of bradyzoids will enter into the human body. Now, these cysts or the favorite area for the Toxoplasma gondii to sit inside the person's body are inside the animal and the person's body are the skeletal muscles. So whenever the skeletal muscles are consumed, they can get into the human's body as well. The second source can be the infected oocytes that are present in the cat feces. Now, once they have entered into the person's body, these porocytes are released and they penetrate the intestine wall. From the intestine, they form tracheozoids are formed usually because of the asexual reproductive cycle that is taking place in the small intestine, and then cells usually rupture, form the hematogenous spread inside the body. Then what happens if the mother was pregnant? These tracheozoids usually crosses the placenta and reaches the infant. Now they infect the fetus, and congenital toxoplasmosis usually results from that. Other than that, they can enter into the musculature or the skeletal muscle of the mother and form cyst over there because of the immune response and formation of the cyst that contains the bradyzoids in the various organs of the mother. Now, this is the whole cycle of the disease, starting from the ingestion of the organism, then its maturation, and then spreading a process inside the small intestine, then into the placenta, and if it stays in the mother's body, into the skeletal muscles. Okay, now coming towards the clinical features, the first and the important clinical features, there are three most important clinical features of toxoplasmosis in the infants. The first one is the hydrocephalus, then we have intracranial calcifications, and then we have chorioamnionitis. Then we have encephalitis, multiple organ infection, epilepsy, mental retardation, and then blindness and stillbirth. All of these are the very dangerous consequences of the infection with the Toxoplasma gondii. Okay. Now, one important feature of the Toxoplasma gondii is the presence of Heffner cells, that are these cells in when we see the culture under the microscope. These featured Heffner cells usually tell us that the infection is of the Toxoplasma gondii origin. Okay, so the next disease that we will be talking about is the erythrovirus or parvovirus 19. So, retrovirus or the parvovirus are responsible for the causing the erythema nodosum. That is a rash, as you can see on the body of this child, and leads to fever and these type of signs and symptoms. The rate of stillbirth with erythrovirus or parvovirus 19 are usually increasing. The characteristic of the erythrovirus under the microscope are the presence of the lantern cells. If you can appreciate these cells over here or these cells over here, they are known as the lantern cells, and this is their appearance under the microscope. So if there is one thing about the erythrovirus that is important, is the presence of the lantern cells under the microscope. Okay. The next one is the human immunodeficiency virus. Human immunodeficiency virus is a disease that can be transmitted to the fetus by three ways. The first one is via the placenta that we have followed in all the previous diseases. The second is during delivery because of the infected birth canal, and the third one is during the breastfeeding if the mother is infected. The other risk factors for the disease are maternal risk factors are low CD4 lymphocyte count, that are the T cells and are responsible for the immune response that is generated inside the body. Then we have a high HIV-1 RNA levels inside the body, acute retroviral syndrome during pregnancy, presence of co-infections, other infections as well, injection during drug use, absence of antiretroviral therapy or prophylaxis, and then we have absence of prenatal care. Other risk factors, ops, if we talk about the ops, the risk factors are going to be duration of the placental membrane, rupture and or chorioamnionitis. Then we have invasive procedures that are used during the pregnancy or for the delivery of the child. Then we have vaginal delivery, that is because if the cervical canal was infected and when the child passes through that infected cervical canal, he or she can be affected by that. Then we have infant factors. The first one is the premature delivery, because a premature child has almost no immunity inside him or her. Then we have breastfeeding. Okay, now coming towards the malaria. If you see this slide over here, now the cells of the malaria or the plasmodium that affects the that is basically the cause of the malaria is present in the maternal blood, that is present in the intervillous spaces and is surrounding them. If you can see these areas are basically showing us the presence of plasmodium into the microvillous spaces, intervillous spaces. Now, in the mother, malaria will cause the normal signs and symptoms that the disease always causes, but in the infant, it can lead to abortion, it can lead to stillbirth, and it can lead to low birth weight babies and many other abnormalities in the children as well. Okay, now we have the Villitis of the unknown etiology. First, we studied about the Villitis that had so many etiologies. The whole list we studied about, there were bacteria, there were parasites, there were viruses, there were fungi, and now we have a Villitis that has no etiology. Now, in this diagram, we are seeing necrotizing over here, if you can appreciate these necrotizings. So basically, Villitis causes a disease of the villous, and villous are the areas that are responsible for the absorption of nutrients. So any necrotizing action inside the villous will as a result cause disturbance in the absorption of the nutrients and the oxygen from the intervillous spaces. Okay, now discussing the causes of the villous edema. Villous edema is when there is fluid accumulated in the villous and they are profound in size. So the first one is the hydrops fetalis. Then we have eruptio placenta. Then we have chorioamnionitis, umbilical cord accidents, fetal malformation, and then finally genetic disorders. All of these somehow contributes towards the villous edema. We have discussed about certain infections such as Toxoplasma before, and also before that there is increase in the size of the placenta, and one of the cause for that increase in the size of the placenta is the villous edema, and causes of villous edema are all these diseases. Okay, now the terminal branches of the villus, if you remember those diagrams we discussed earlier in the lecture, those branchings, those terminal branches are usually enlarged, and these are the areas that are usually seen with the enlarged branches. Okay, so in this lecture we have discussed about the pathologies of the placenta and pathologies of the umbilical cord. Our main focus was on the anatomy of the placenta, then we moved towards the pathologies of the umbilical cord, and then finally we discussed a hell lot detail of the placental diseases. We have discussed about so many organisms, so many bacteria, viruses, mostly they lead to the disease, and then finally at the end we have discussed about one disease that had unknown etiology, that was the Villitis, and then finally the villous edema. So this was all from this lecture. Thanks for watching sqadia.com.